But if you have someone, let's say, who develops the same symptoms of agitation, of hallucination, of paranoia, of sleeplessness, and let's say that person hasn't done crystal meth, and hasn't done ketamine, and hasn't done any drugs whatsoever, what would Szasz say about that? I think that he would probably say that there's no evidence that those symptoms in that person are caused by abnormal activity at any brain receptors. He'll say there's no evidence. You can't scan it, you can't measure it, you can't see it on an X-ray. So therefore, it's not there. Therefore, it's not an illness. Therefore, it's a problem in living. Therefore, someone's choosing it. Therefore, it's a behavior. So, again, you've got identical symptoms that on one hand can clearly and are clearly and do clearly get caused by physiological disturbance, physiological activity, in this case drugs. And you've got other symptoms that are identical that Szasz would shrug his shoulders and say, well, they may be identical, but I don't see a physiological thing, therefore it's completely separate. And that truly makes no sense. In reality, in this hospital around me right now, and in dozens of other hospitals all over North America, many people with substance-induced psychotic symptoms are effectively managed, effectively treated, and effectively kept safe by psychiatrists and the colleagues of psychiatrists. Our colleagues in neurology are experts in their field, and I would certainly have nothing against a neurologist looking after me or anyone else that I cared for. But most neurologists would not think for a minute that they were particularly qualified or particularly prepared to treat acute psychosis arising from the use of drugs or from delirium. These are physiological manifestations, these are physiological causes of the psychotic symptomatology, but no neurologist that I know would want to own that. That is the realm of the psychiatrist. And that really shows how out of touch Szasz is in terms of what his understanding of what a psychiatrist does. Every day in this hospital and elsewhere, our colleagues in surgery and medicine call psychiatrists, call teams of psychiatrists to assess and manage delirium on the surgical wards and on the medical wards. That includes identifying the physiological and the medical sources of the symptoms as they are being treated. Psychiatrists are the expert in that. Szasz's rigid categorization of symptoms and problems as either mind-based, i.e. mental illness or mythical illness, or brain or body-based, is simply a non-entity in modern medical practice. The question is, do you want to understand and help a patient, or do you want to fight over particular words or particular definitions of illness or treatment? And I think that the answer is pretty clear. Just looking at some other examples of illness and the modern idea of illness, and there being a whole lot of different ways of looking at it other than Szasz's that are perhaps a lot more appropriate. We get to hypertension or high blood pressure. In hypertension, you can't see it. There's no tissue pathology. You only can measure it on a continuous scale when you go to the pharmacy or you go in to see your doctor. And the definition of the condition is purely a committee-driven decision. Do you have the disease of hypertension when your blood pressure is 130 on 80? Do you have it when your blood pressure is 135 on 85? Do you have it if one of those figures is taken in the pharmacy and the other one is taken in the doctor's office? Do you have it if one of those figures is taken at home? How many assessments do you need at a certain level before you make the diagnosis? Is it just one time of an elevated blood pressure? Is it 3 times? Is it 10 times? These are all questions that have been settled essentially by committees of experts looking at data and figuring out where to draw the lines. In Szasz's world, hypertension is not an illness, yet it's something that millions and millions of people are treated for every single day. Billions of dollars are spent on medications and other treatments for it, and it's an extremely important part of everyday medical practice. Same thing with cholesterol levels. What are the currently accepted guidelines for appropriate cholesterol and lipid levels? Have they changed over the past 15 or 20 years? Absolutely. Have they gone up, the cutoffs? Have they gone down? Will they stay the same today, tomorrow? What will they be in 20 years? In Szasz's world, we're inventing illness. We don't look at cholesterol under a microscope and say, there it is, there's the problem. We define ourselves what is a reasonable or healthy or normal level of cholesterol, and we go from there. But that changes, that shifts, and there's nothing physiologically different between a level of X and a level of X plus 0.002. But that may be the difference in whether you're treated or not, whether you're diagnosed or not. It's also interesting to look at some of our medical colleagues in cardiology and their interest in one of our conditions or illnesses, depression. What they found over the years is that the presence or absence of depression is one of the strongest indicators of how well someone does or will do after having a heart attack. Even with the exact same heart attack and the exact same physiological function and the exact same lesion in one's heart, the exact same problem with the heart muscle, the patient with depression is going to have a greater risk of dying from a cardiovascular related disease going forward than the person without depression. And cardiologists now see depression as a cardiac risk factor. And what they do is they treat depression, and they ask psychiatrists to consult and to treat depression. Because what the cardiologist wants more than anything is his or her patient to not have another heart attack and to be well from a cardiac point of view. So even though the hearts are exactly the same, it's the presence and absence of depression that makes the difference in terms of how well someone will do from a cardiac point of view. That's modern medicine. And that's the reason why members of my department worked very, very closely with members of the Department of Cardiology in taking care of patients. And Thomas Szasz has nothing to say about that.